Hello, I'm Lisa Unger. This is assignment 2 in HNO7013. This assignment will focus on adolescents aged 13 to 17 years who have been diagnosed with generalised anxiety disorder, or GAD. GAD is the most common anxiety disorder affecting children and adolescents, with statistics between 9 and 32%. Statistical data indicates a higher incidence of GAD in females with maternal psychiatric history and a lower maternal educational attainment. Furthermore, the risk of GAD increases with the stress of biculturalism and prejudice in culturally diverse adolescents. Furthermore, the rural environments may elevate risk due to limited service availability and a lack of multicultural support. Other psychosocial factors include loneliness, suicide ideation, and depressive moods. In some cases, when GAD presents as severe, pharmacological measures are taken by child psychiatrists or, where possible, paediatricians and GPs. A GAD diagnosis in adolescence requires persistent excessive worry for at least 6 months, accompanied by symptoms such as restlessness, fatigue, difficulty concentrating, irritability, muscle tension, and sleep disturbances. Parental involvement, consent, acceptance of their child's diagnosis, and participation in CBT is essential for the success of treatment. Establishing a therapeutic alliance for CBT with adolescents can be challenging as they struggle with foundational aspects like articulating problems, and they may lack necessary verbal reasoning skills. Alternatively, modalities such as play or creative art therapies may be advantageous for some. Significant disabilities and comorbid psychiatric or bipolar disorders warrant exclusion from CBT, as the associated mood dysregulation and distorted reality can compromise treatment outcomes and pose ethical concerns. As substance effects can mimic or worsen anxiety, complicating the distinction between GAD and substance-induced anxiety, adolescents with substance abuse are also excluded. Individuals with acute risk of harm to themselves or others are excluded, as their immediate risk for crisis intervention and stabilisation supersedes outpatient therapy. Session frequency for adolescents with GAD is determined by their suicide risk. For minimal suicide risk, a treatment typically involves 10 to 12 weekly sessions of about 50 to 60 minutes, with a total number adjusted based on the client's progress. Moderate risk requires a more intensive approach with 2 to 3 weekly sessions and supplemented with phone check-ins to ensure there is safety. Given the comparable efficacy of face-to-face and online therapy formats, the choice of session modality for this assessment will be at the client's discretion. Research indicates that for adolescents, individual CBT is more effective than group CBT formats, as it can be tailored to the client's unique needs. Administered by a qualified professional, this CBT intervention program integrates traditional methods like thought diaries and worksheets with digital tools to enhance engagement and skill consolidation. A clinician diagnoses GAD using the DCM-5 criteria, a comprehensive assessment of the adolescent's functioning, stresses, coping skills, and vulnerability factors such as cultural background and gender identity. To measure severity, tools like self-reported GAD-7, the Penn State Worry Questionnaire, and the clinician-administered Hamilton Anxiety Rating Scale can be utilised. During the initial assessment phase, a comprehensive evaluation of individual vulnerability factors will be conducted, with particular attention paid to the adolescent's socio-cultural context, including their cultural background and gender identity. Client progress will be tracked at each session using the Beck Depression Inventory Scale to provide measurement-based care. This tool offers insight into the severity of anxiety and depression, while also monitoring for suicide risk, hopelessness, sleep disturbances, and compulsive behaviours. Finally, to gather comprehensive feedback on the therapeutic process, the Cognitive Behaviour Rating Scale from the Beck Institute is used to gather critical information assessing the therapist's skills. conceptualization, and their techniques. The program sessions outline provides a flexible framework to be implemented collaboratively with the adolescent. The primary goals are to foster hope, to maintain therapeutic alliance, and to enhance the client's well-being and daily functioning. All sessions follow a structured format, beginning with the GAD-7 mood assessment and weekly review. The foundational first session establishes rapport, defines issues, and provides psychoeducation on anxiety and the cognitive behavioural model. Collaborative SMART goals are set, and each session concludes with a summary, an action plan review, and client feedback to allow for dynamic treatment adjustment. Session 2. This session enhances self-awareness through psychoeducation, teaching adolescents to identify physical, cognitive, and behavioural signs of their anxiety. A core homework task is using a thought diary to track worries and triggers. A collaborative action plan is then established, incorporating CBT strategies such as thought monitoring, behaviour experiments, and mindfulness, while also preparing for the next session. Session 3 includes the initial coping skills of diaphragmatic breathing and muscle relaxation. They are introduced to manage psychological anxiety symptoms. The action plan is reviewed to ensure task completion and goal relevance. Homework focuses on practicing these relaxation techniques, using the thought diary, and engaging in mindfulness activities as outlined in the action plan. Session 4 and 5. These sessions focus on cognitive restructuring, where adolescents learn to identify and evaluate their automatic negative thoughts and cognitive distortions. The therapist employs Socratic questioning to facilitate critical self-reflection. The therapist also introduces behavioural experiments to test the validity of anxious predictions. In-session worksheets support in challenging anxious distortions, and homework requires the adolescent to apply and document these skills in their thought diary. Session 6 introduces the principles of exposure therapy, explaining its rationale as the gradual, systematic confrontation of feared situations to reduce avoidance behaviours. The primary task is to collaboratively create a fear hierarchy, a ranked list of anxiety-provoking situations, alongside a review of the action plan and the goals. Homework involves using the thought diary to log successful exposures and completing mindfulness worksheets. These sessions follow on from 6, focusing on exposure, guided by the collaboratively constructed fear hierarchy. Starting with low-level items, the adolescent confronts feared situations with therapeutic support, applying cognitive and relaxation skills until the anxiety naturally subsides. This process is crucial for building self-efficacy and resilience. Review feedback to see if restructuring of the sessions is required, and homework is to review the action plan, engage in uplifting activities and document them, document outcomes in the thought diary of exposures to any fears, and continue mindful exercises. This session introduces formal problem-solving skills for managing life stresses, a collaborative process of brainstorming solutions and evaluating outcomes. A dialogue of tapering the treatment is also initiated, with plans to extend the time between final sessions to assess progress. Homework focuses on applying problem-solving skills, using the thought diary to prepare for last sessions, and continuing mindfulness and breathing exercises. In this session, the adolescent creates a personalised relapse prevention plan for post-treatment self-management and consolidating their therapeutic gains. This involves identifying early warning signs of anxiety and compiling a toolbox of mastered coping strategies such as goal setting, mindfulness, cognitive restructuring, and confronting avoidance. Homework focuses on preparing for the final session. It includes providing the client with the cognitive therapy rating scale to gather comprehensive feedback on the therapist for the final session, using worksheets with questions that cover the adolescent's therapy experience, documenting success in the thought diary, and continuing relaxation practices. In this final session, progress is reviewed via the action plan, successes are celebrated, and future follow-ups are scheduled. The relapse prevention plan is thoroughly reviewed to reinforce the adolescent's capacity for independent self-management, supported by self-therapy worksheets covering key skills. The session includes reflective activities, and a summary email outlining the therapeutic journey is sent afterwards. The inclusions of techniques used in this CBT program were included due to the evidence-based research. For example, psychoeducation is paramount in normalising the behaviours and educating adolescents and their parents about anxiety and CBT, as described in Steid et al. 2023. The efficacy of cognitive restructuring, a technique that trains clients to identify and evaluate their automatic negative thoughts and cognitive distortions, is empirically validated by Joyce, Boulay, and Zabowski 2021. In vivo or exposure therapy, which provides opportunity for the adolescent to safely expose themselves to their fears using learned skills to prevent patterns of unrealistic thought processes, is evidenced through research by Weschler et al. 2019 and through the guidelines of Beck 2021. The importance of feedback guides the therapeutic journey in a positive, goal-focused direction and is evidenced in the research by Jance et al. 2016 and Beck 2021. This program's client-centered methodology is actualized through the collaborative development of action plans and SMART goals, approaches empirically supported by Stallard 2022 and Beck 2021. The intervention is recovery-orientated, providing practical skills to help adolescents navigate their mental health journey rather than focusing solely on the cure, as outlined by Halder and Mahoto 2019. The fundamental principles applied throughout this program are substantially evidenced for their efficiency and efficacy in treating adolescents in the research by Bide and Kustaf 2020 and Kars 2014. That completes my program. Thank you for watching, and here are my references.